卫生福利部部长 Mr. 施金水 Director of Office of International Cooperation, Ministry of Health and Welfare, Taiwan. 医师公会全联会暨中华民国无任所大使吴应东大使。医师公会全联会理事长周庆明，医师公会全联会国际事务委员会蔡思之委员，医师公会全联会张必正秘书长，部立台中医院李孟智顾问，立法委员王正旭立法委员。还有医福会副执行长林明南教授，健康亚洲董事长蔡笃坚教授，医师公会全联会常务理事蔡有成常务理事，医师公会全联会谢蔡堂教授，不知道还没有介绍到的贵宾。Okay. We have various topics to share in this 2 hours and 20 minutes symposium, followed by panel discussion. The Taiwan Medical Association is honored to organize this special event with the World Medical Association. First, allow me to introduce the Dr. Ashok Philip to say a few words for us.
Good morning. Honorable Dr. Tai Yuan-Chu, Minister of Health and Welfare of Taiwan, and also WMA Council member, Dr. Ching-Ming Cho, President of the Taiwan Medical Association, Dr. Brian Chung, my friend and Secretary General of the Taiwan Medical Association, Dr. Jung Yul Park, Chair of the WMA Council, Dr. Otmar Kloiber, Secretary General of the WMA, new friends, old friends, colleagues. It is my honor to welcome you all to this international symposium on universal health coverage and integrated healthcare systems, engagement and strategies. On behalf of the World Medical Association, I would like to thank the Taiwan Medical Association for all the hard work and precious time they have put into organizing this important and very relevant conference. I see that we will hear from experts from many countries as well as a non-expert myself over the course of the day, and I'm confident that all of us will benefit from the intellectual cross-pollination such meetings engender. The Taiwan Medical Association is a truly valued part of the WMA and participates actively at the General Assembly, the Council, and in the working groups of the WMA. Throughout the nearly 1 decade that I have been attending WMA meetings, I have been consistently impressed by the high standard and the active manner of the Taiwan delegates' participation. Among many contributions, I must pay special attention to the TMA's contribution to the travel fund for the Junior Doctors Network. As many of you are aware, our junior doctors are passionate and active participants in our activities with partner organizations, and without the TMA's contributions, the WMA would be greatly constrained in sending this next generation of leaders to these important meetings. Now, the WMA, as a matter of principle as well as pragmatism, strongly supports and advocates for the active participation of Taiwan in the WHA and WHO technical committees, and we believe that inclusivity and autonomy are important in ensuring that vital health and healthcare issues are discussed comprehensively. Well, as all of us are aware, we are firmly in the age of pandemics, and it's likely that the most dangerous future pandemics will be viral illnesses. And overcoming these will require international cooperation and information sharing. And in most cases, vaccines will be our way out of the crisis. Therefore, it's very important to have a reliable and comprehensive international system that can be used to verify the vaccine status of patients and especially of international travelers. And therefore, the WMA feels strongly that Taiwan should be independently included in this global electronic vaccination certification system. Now, this should never be a political matter. It is purely a pragmatic way of ensuring that information in this system is as accurate and complete and up-to-date as possible. And in the end, this is a truly common good and should not be objected to for political reasons. And finally, let us hope that the discussions and presentations awaiting us will inspire us to keep pressing forwards to the goal of universal health coverage. It is, of course, not an easy goal to reach, and even after reaching it, maintaining it is going to be hard and expensive. But a world where health coverage is uneven is a vulnerable one. Diseases spread more rapidly, and morbidity burdens everyone. So let us work to ensure that the WHO member states recognize this and commit themselves anew to continue working towards truly universal health care. And finally, I would like to extend my thanks and the WMAs for the opportunity to participate in this important and timely meeting. I hope to learn more about this vital subject. Thank you.
Phillips, for your wonderful remarks. Now let's welcome Dr. Jung Yul, President of Taiwan Medical Association, to deliver his open remarks. Please, President Zhou.
Dr. 蔡元秋，邱泰元部长 ，Minister of Health and Welfare. Dr. Ashok Philip, President of World Medical Association. Dr. Jung Yul Park, Chair of Council of WMA. Dr. Otmar Kloiber, Secretary General of WMA. Ladies and gentlemen, good morning. It is an honor to host the International Symposium on Universal Health Coverage and Integrate Healthcare System Engagement and Strategies, organized jointly with the World Medical Association in Taipei, Taiwan. I would like to express my deepest appreciation to the World Medical Association on your continuous support for Taiwan and the TMA. I will also welcome all of you to attend this symposium. Universal health coverage is a system that ensures that everyone, regardless of their income level or social status, can access essential health service without facing financial hardship. It promotes equity, improves health outcome, and contributes to overall social and economical development by reducing poverty and increasing productivity. In 2015, the WHO emphasized that importance of integrated healthcare system, and integrated healthcare system focus on coordinating various aspects of healthcare delivery, including primary care, specialty care, mental health service, and the social service to provide comprehensive and seamless care to individuals and the communities. This approach aims to improve efficiency, effectiveness, and accessibility of health service while enhancing patient with the outcome and experience. During this conference, experts will share their knowledge and insights to help us identify the best strategy and engagement methods for achieving UHC through integrated healthcare system. This year, we are glad to have Dr. Ashok Philip, Dr. Jung Yul Park, Dr. Brian Chang, and Dr. Li孟智, who will deliver the brilliant speeches with us. A panel discussion will be led by Professor Dr. Wang Zhenshu following the speeches. Professor Dr. Wang Zhenshu currently serves as Legislator of Taiwan. Through sharing and exchanging the experts, I wish we all benefit greatly from the innovation of knowledge and the valuable lessons. I would like to extend my sincere gratitude to you, your participation and the contributions, and wish a tremendous success of the symposium. Thank you.
Thank you, President Zhou. Now it's our honor to welcome Professor Dr. Tai Yuan-Chu, Minister of Ministry of Health and Welfare Taiwan, to give us a precious remark.
Dr. Ashok Philip, President of World Medical Association. Dr. Jung Yul Park, Chair of WHO Council. Dr. Otmar Kloiber, Secretary General of WMA. Dr. Qingming Zhou, President of the Taiwan Medical Association. Dr. Bizeng Zhang, Secretary General of Taiwan Medical Association. And Dr. Wu, the Ambassador at large. And the distinguished and the legislator, Dr. Wang Zhenshu, and the distinguished guest, esteemed colleagues in the medical field, ladies and gentlemen, good day. It is a great honor to participate in the conference, which focuses on one of the most critical topics in global health governance today, advancing and achieving the goals of an integrated healthcare system. First, I would like to extend my heartfelt gratitude to the World Medical Association for its long-standing support of Taiwan's participation in the WHO and the WHA. I sincerely hope that President Dr. Ashok Philip, Chair Dr. Jung Yul Park, and the Secretary General Dr. Otmar Kloiber will continue to advocate for Taiwan on the international stage, helping Taiwan contribute further to global public health. At the same time, I would like to thank the Taiwan Medical Association for its consistent role as a vital bridge between the government and the medical community, actively assisting in the promotion of various policies and fostering the continuous development of Taiwan health care system. I also look forward to Taiwan Medical Association expanding collaboration between Taiwan's medical sector and the international community, contributing further to the enhancement of medical service quality. As highlighted in President Lai Ching-te Health Taiwan policy initiative, health is not only the responsibility of individuals or healthcare institution, but rather a common mission for our nation. Facing the challenges of an aging population, declining birth rates, and a shrinking workforce, our vision is to construct an integrated healthcare system for public health services founded on strengthened primary and community care, thus fostering inter-department collaboration and resources sharing. We aim to provide our citizens with higher quality and more accessible healthcare services, ultimately creating a health, safe, and sustainable society. Thank you all for your participation today. Today is also have the live streaming, so I think more than several hundred physicians will see this our conference. And I look forward to the innovative insights that will emerge from the discussion as we work together to advance global health. Finally, I wish the conference every success and wish you good health and great success. Thank you.
Thank you. Please stay on the stage, Mr. And we now, with distinguished guests and senior official, ladies and gentlemen, we will take a photo. So, please return to the seats, and we will take the whole picture. 部长要不要先坐一下，拍个照再走？对，他要坐在前面。哦。OK。Okay, thank you for your cooperation. Distinguished guests, ladies and gentlemen, we are moving on our first session. We are very delighted to have Dr. Otmar Kloiber, Secretary General, World Medical Association, to serve as our moderator. Please join me to give a warm welcome to Dr. Kloiber.
Thank you very much, Colin, and good morning, distinguished guests, excellencies, colleagues, friends, teachers, who are here together with us to discuss two important topics this morning in our first session. In a symposium that is called International Symposium on Universal Health Coverage in Integrated Healthcare System Engagement and Strategies. Now, let me say it's an honor to be here in Taiwan and discussing this topic. Why? Universal health coverage for us is one of the most important aims that the World Health Organization follows currently. It is the most far-reaching aim, but also the most encompassing and important one in its work, because we strongly believe that this is the way to really bring healthcare to all people. It is aspirational, yes, because you may argue that nowhere in the world universal health coverage will be ever complete and total. That is correct. But it is an honor to be here in Taiwan, because Taiwan is one of the countries which is probably in a group of a few countries coming closest to this aim of having universal health coverage, and you have reached this in a very short time of building a health system. Yesterday, we had a chance to see TSMC, the world leader in producing microchips. And this development, this astonishing development of Taiwan from just 60 years ago being one of the poorest countries in the world, now to being the industrial leader in this modern digitization of this world, is astonishing, but I think it's also closely coupled to the development of a welfare and health system in this country. I don't think one can happen without the other. And therefore, I think universal health coverage is more than just providing health care to all people. It is also a matter of social stability and economic success. I have now the pleasure to introduce to you Dr. Ashok Philip, the president of the World Medical Association. Dr. Philip is a doctor of internal medicine, a specialist from Malaysia. He is past president of his home association, the Malaysian Medical Association, and active in the World Medical Association since 2015. He has been chairing the work group on governance review in the World Medical Association, which has led to some changes in our internal structure. He has led the advocacy committee of the World Medical Association and has been serving as a committee member in our global family of medicine. And one of his outspoken aims is to help raising the profile of smaller medical associations within the World Medical Association. His topic will be universal health coverage, getting there from here. Dr. Philip, please.
Thank you for the kind introduction, Otmar. And hello again. So today I am to speak to you about universal health coverage, but I'm not really an expert on universal health coverage. So I thought I'd speak more about how it can be either easy, or not easy, but less difficult, or much more difficult to get from where you are to the true universal health coverage. And in doing so, I will be speaking about the situation in my own country, Malaysia. So first of all, what is universal health coverage? Well, it's a goal that all governments, or almost all governments, profess to be moving towards, and perhaps a few even think that they have achieved it. But the definition of UHC by the WHO states that it has been achieved when everyone in a country has access to the full range of quality health services that they need when and where they need them without financial hardship. So if you look at this strict definition, I think no country has completely achieved it, though obviously some have come much closer than others, and Taiwan has come very, very close indeed. But there's always something, either it's not everyone in the country who can get it, maybe foreigners don't get it, or you can get it, but you have to wait a long time, or you might have to pay some money and that might cause you some hardship. So always there'll be something that detracts from 100% achievement. So, as I said, sometimes long waits, sometimes long travel, especially in larger countries and with underdeveloped rural areas. Even in my country, there are areas which are practically jungle, so people living there have difficulty in getting access to even primary health care. Now, just a brief history about how people have been thinking about it. And I think nobody will argue that the first national social health insurance scheme came to be in the 19th century newly unified Germany, the brainchild of Otto von Bismarck. Of course, the system has changed since then, but generally speaking, more and more people have been brought under its umbrella. And there's broad input from the public, employers, etc., about how expenditures should be targeted. Another notable example, of course, we can't leave out the British national health system. It's one of the best known, if not actually the best system. It was created after World War II by the Labour government. So basically, an act of parliament created the national health system. And it was at the time of its creation, its basic principles were that it should be comprehensive, universal, and free at the point of delivery. Now, there have been many changes since then, and patients do have to pay for some things. Some places they have to pay prescription charges, etc. And recently, many have been saying that it's going to collapse. But if I think back, I think for more than a decade now, every politician has been saying, oh, the NHS is going to collapse, the NHS is going to collapse. They say we are chronically underfunded and we have shortages of staff. But, well, it's still running, and I think many Britons are very satisfied in general with it. And of course, I cannot leave without saying something about the National Health Insurance Scheme, which dates back to 1995. I believe there was some issues with the reimbursement at the beginning, and it's changed from fee for service to global budget. The patients are very happy with the system, I believe. Doctors perhaps not so happy, but they're okay. And it's recognized as one of the best healthcare systems in the world, objectively. So I think from looking back at that, we can see that to have any chance at succeeding, a national healthcare system must have a strong legislative foundation. It must have sustainable financing, and it must have stakeholder investment. And these are not easy conditions to meet, especially the sustainable funding part. And despite this, many countries are trying to reach the UHC goal, but they all start from unique starting points. So because the starting points are so different, the path that they will take will be different. So it's not possible to copy wholesale and copy and paste from one model to another situation. So there's no foolproof way to get to UHC. Now let me go to my own country. As you know, it was a British colony, and we only achieved independence in 1957. During the colonial era, the British built hospitals, general hospitals, in the larger towns. Every state capital had a general hospital, and some of the larger towns in some states. The primary care clinics were inadequate, and they were situated again mostly in close to or in urban areas. So the rural and the remote areas were very poorly served. And these primary care clinics were generally not staffed by doctors during the colonial era because we didn't have that many doctors. At that time, there were very few private hospitals. It was not really an idea whose time had come. It was these private hospitals were run mostly by religious bodies like the Catholic Church or by charitable foundations. So there were private general practitioners, but almost all of them in in urban areas, because that is where I suppose the patients were, and that's definitely where the money was. So after independence, I must say, I must commend the governments of that day because they gradually expanded the primary care clinics. That's where I think they had the right focus. They didn't focus so much on tertiary and specialized care. They expanded the primary care clinics. So in the peninsular states, they moved out into the rural areas, quite remote areas. In the states in Borneo, it's much more difficult because even though the road network is almost non-existent at the time, so they had a flying doctor service, and they also had mobile clinics in areas which needed them. The number of hospitals in the public sector also gradually increased. And the result of all this was that indices such as infant mortality, maternal mortality, and life expectancy at birth improved greatly. And the services provided by the government at the time were comprehensive and they were very cheap. In fact, they still remain very cheap. If you want to see a doctor in the government service, general practice, you pay the equivalent of 20 US cents. If you want to see a specialist, you pay the equivalent of $1 US. And that includes seeing the doctor, all investigations, all medications. So it's almost free. But it was restricted, of course, to citizens and permanent residents. So at that time, you could say that we practically had universal health coverage because almost every resident had easy access to whatever health care they needed, almost no charge, but sometimes very long waiting times. There were, however, constraints. It wasn't all roses. It had relatively low spending on health. About 3 to 5%, less than 5% generally of GDP was on health. So it would have also rather low manpower as far as doctors were concerned, because at the time when I started work as well, there were less than 1,000 doctors joining the government service per year as interns or housemen. And to make sure that the government had at least enough doctors just to cover the basic services, there was an act of parliament making it mandatory for all citizens coming back to register as doctors in Malaysia to serve the government for 3 years. So this compulsory 3-year service meant that the government could actually keep wages quite low. So after 3 to 5 years, obviously because of low wages, a lot of them left government service and opened their own private clinics. And those who stayed usually stayed because they wanted to specialize. So because of the compulsory service, what we had was low wages, and because it's very cheap, almost free, we also had a very high workload. So this combination of relatively low pay and overwork obviously led to discontent among the doctors. Now the law in Malaysia is that essential services cannot strike. So doctors are not allowed to go on strike. But because we were not allowed to go on strike, there were certain innovative strategies by our doctors, such as work to rule. You know, you are supposed to work for a certain number of hours, you work for that number of hours and then you go back. And so this led to backlogs. And because of that, on a couple of occasions, the government was forced to drastically increase doctors' pay. But the Prime Minister then, who I'm sorry to say was a doctor, was not happy with this. He decided there were too few doctors, and therefore they have too much bargaining power, and therefore they can hold the government to ransom, and that's not a good thing, according to him anyway. So what did he do? Being a doctor, he thought there must be a simple cure for this, and he decided the cure was produce more doctors. So he did it, but handing out licenses for private medical colleges and also increasing the number of government medical colleges. So the result of this was that we now have more than 35 medical programs, private and public, in a country which only has 30 million people. And together with graduates coming back from overseas, the number of doctors joining the medical service increased from less than 1,000 to 5,000. You know what a fuss there was in Korea when the government wanted to double the number of doctors. But in Malaysia, we're not so strident, we're not so militant, we're not so activist, but we warned the government. And we warned the government every single year for 20 years. And they listened not at all. So the problem is not that you're just increasing the number of doctors who are coming in. There's also the problem of quality. I mean, how can you go from 1,000 to 5,000? How can you find 5,000 people who have a passion to do medicine? A lot of these doctors, these new doctors, were there because either their parents forced them or the government gave them scholarships because they had good marks. But they're not interested in medicine. And you come back and you're not keen on medicine, and then you have to work 24 hours, 36 hours, and they couldn't do it. And there was no proportionate increase in the government hospitals or in the number of trainers. So the number of doctors increased. Let me show you in this rough slide. This is not strictly speaking the number of doctors. This is the number of annual practicing certificates issued. And it shows the number of practicing doctors, those who have finished their housemanship or internship. When you're a houseman, you have a provisional certificate. This is the annual practicing certificate. And as you can see, from about 2007 onwards, the number just started to rise rapidly. And this is not complete. At present, we have about 70,000 plus, from about 10,000 plus. But the number of government hospital beds nearly doubled. So we've got a nearly six-fold increase in the number of doctors, and the number of hospital beds has only doubled. And therefore, each doctor, each houseman especially, is seeing far fewer patients, which is not adequate for training. Now, the thing about Malaysia is the law mandates that the government must employ and train every citizen who comes back with a recognized medical degree. So every houseman has to join the medical service. He has to be offered a job. But the number of posts created was not increased sufficiently. Towards the end, what they were doing was taking 3 posts for nurses and amalgamating them to employ 1 doctor. So that it shows you it's just a stopgap measure. There was no long-term planning or thinking, despite regular warnings from the MMA. So the waiting time to be employed became longer and longer. You graduate. When I graduated, I was employed within less than a month. When things became to this pass, it could be more than a year. So you're sitting around having spent $500,000 ringgit, or about about 100,000 US dollars of your parents' money or the government's money. You pass, you come back, and then you sit and wait for a year, by which time you've forgotten everything, and then it starts all over again. So finally, the government said, okay, we'll hire these doctors on contract. If you're on contract, you don't have to have an approved post, you just hire them. And they were hired. So the problem is, if you're a contract doctor, you don't get the chance to specialize in the government's sponsored programs. So you're employed for 3 years or 4 years on contract. And after that, what happens? Where are we going to get specialists to train? So all these things were just like stopgap measures. They didn't understand what's going on, and nobody wanted to take overall responsibility because the prime minister who had started all this had long ago left. And no one wanted to touch this because they knew it's going to collapse. And they didn't want to be the ones who touched it just before it collapsed. We as doctors know you handle a seriously ill patient, he dies, and then they blame you. So again, the increasing demand in government hospitals because of very cheap care was causing a severe overload. the same PM at the time, decided the best solution was to get more private sector involvement. So he made sure that big companies had to offer insurance coverage to their employees, mostly for inpatient care, and then encouraged private hospitals, which are often owned by government-linked companies, to expand. So the number of private hospitals rose from about 50 in 1980 to 200 in 1995. And the beds rose from 1,200 to 7,000 then. Now they're only about 210, but the number of beds has more than doubled. So basically the hospitals have become bigger and added more beds. So you can see that the government sector has only doubled. The private sector has gone about 15 times in size. Obviously, once you've got that sort of expansion, you need specialists. And where are you going to get the specialists but from the government sector? So you may have stopped, you may have made it difficult for junior doctors to leave. You may have enough junior doctors, but now all your specialists are leaving and there's not enough left to train and serve in public hospitals. So in order to counteract that, they instituted limited private practice. You can go to private practice two days a week, and some hospitals have private wings where you can go and see your own private patients. But you know what happens then. Instead of taking care of your government patients, you rush off to your private clinic. And then when your private clinic patient needs expensive investigations, you send them to the government sector. So in the end, the only person benefiting is the specialist. So what's happening now, the conditions for the junior doctors remain terrible because after their contract is expired, completed, some of them get absorbed into government service, but some of them are left without any job. And it's not clear how they are selected because the criteria are not clear. Some of our junior doctors are very hardworking. They can go and sit for postgraduate exams, they pass the part 1, pass the part 2, and then they don't get a permanent job. So now what are they going to do? So the number of specialists, as I told you, has also dropped. The demand for private medical courses has dropped a lot. Some of the courses have gone bankrupt. Others are not able to fill their quota with local students. They have to go to foreign students. And what is happening now is, this is just before I came, the number of medical graduates registering to be on the medical register has nearly halved in 6 years. And the total number of new registrations went from 6,100 in 2017 to 3,100 in 2022. And this started obviously before the pandemic. So graduates from foreign universities dropped from 2,000 over to 725. So there's now a shortage of housemen because my daughter is working in a large hospital in Kuala Lumpur, and she says some wards have no housemen at all. And this is the major hospital in the country. So the Malaysian Medical Association, of course, is tempted to go and visit the minister and say, we told you so. But we won't. So what can we do? We cannot say that, just wash our hands of it. Because for all the problems, the healthcare system works well. But it can't go on like this because the budget, though it's increasing, is increasingly being spent on emoluments, on wages, and not on development, not on building new hospitals. So we have to change. But the public, whenever changes are proposed, reacts badly. Because for all that they complain, they don't want to pay more. And they don't want payroll reductions. They don't want mandatory insurance. So every time a government has proposed these things, the public backlash has led to them withdrawing it because of the 5-year election cycle. There's no way we can reform the health system within 5 years. So they look at the upcoming general election, they pull back the proposed reforms. Fortunately, last year, they managed to pass a health white paper with bipartisan support. So that means that at least both sides are committed to reform, but the white paper is very, very vague on the details. And much more work and meaningful consultation is needed, and I have to say meaningful consultation because most of the time the ministry regards consultation as a KPI. They do it, okay, we've done it, but they don't listen to what you have to say. I dare to say that if they had listened, they wouldn't be in this position now. So what I would say to you is getting to UHC in Malaysia would have been much easier 40 years ago, because the public healthcare sector was taking care of almost everything. Private healthcare was very small. Now, there's a huge private healthcare sector. The amount of money spent in the private side is equal to the amount of money the government spends. And integrating the two will be very difficult. And I think we have reached this position because we have had easy, fashionable solutions to single problems. They don't look at the whole problem. And so the way out is, of course, for everyone to work together, but especially the doctors must unite and speak more forcefully, because I believe that we are the only ones who are thinking of the patients. The politicians are thinking of the votes, and we are just thinking of our patients. Thank you.
Thank you very much, Dr. Philip, for this insight into the attempts in Malaysia to reach universal health coverage, or how this relates to the health workforce and the workforce development in order to achieve such an aim. We are progressed in time, and we will have a discussion round at the very end of this meeting, so I have to ask you to hold questions and the discussion to then. And it is now my pleasure to introduce to you Dr. Jung Yul Park, or JP as we call him, the chair of the World Medical Association Council. Dr. Park is a neurosurgeon from South Korea, from Seoul. He is a board member of the Korean Medical Association, and as a professor at the Korea University College of Medicine, he is a very engaged academic teacher. And as such, he has been also the organizer and head of the 2019 World Conference on Medical Education, which was a very big success at that time in Seoul. He is addressing a very important question which we as physicians have to deal with, namely the climate change, health crisis, and health inequalities, a topic that we at the World Medical Association are dealing now for close to 20 years and trying to bring this to the political arena. Dr. Park.
Thank you, Otmar. And once again, it is my pleasure and honor to be here following last year. Some of students might be surprised why neurosurgeon like me are interested in climate medicine. I lost one of my best friend from heat stroke when he was 55, 10 years ago. I don't look like 66 now, but did you know the Taiwan lost more than 100 citizens every year for the last 5 years from hypothermia? From 2018, there was the 234 deaths, and following year 226, 99. Last year, there were 146 deaths from hypothermia. Not from so cold weather. It was only 5, 6 Celsius, but they were lost from mostly the northern area and the Kaohsiung area. So and last week, 2 days in last week in Korea, there was the heaviest rain, heaviest snow in 117 years. We had 65 centimeter of snow in 2 days. Actually, it was 24 hours. And this year, June, we had more than 1 meter of the rainfall in just 2 days. In Japan, there were, unlike 10 years ago, before a long time, more than 2 meter high of snow in Japan, many areas in Japan. So the world is changing, and the climate is changing. I don't call it climate change. I now call it climate crisis. And what it does is that it has an impact, great impact on health. and health system that we have. So it is most likely cause the health crisis as well. So today, I'd like to talk about from last year. It will be mostly updates from last year, but this time I would like to focus more on the health equity, health inequality. So when you look at the statistics, other than the occasional volcanic eruptions, most, if not all, are the cause of global climate changes by human. I would say more than 90%. It is a cause of the climate change, and the human, we are the cause. And most likely, although it's not increasing steeply, it'll still increase until end of this century. Now we have 8.1 billion population, and India has surpassed China as of this January, and we will have more than 11 billion population at the end of century, and close to 10 billion in 2050. So it will increase, and if you just look at the number of increasing, and we can expect the more human factor causing climate change. We know that these are four major the human causes of climate change, and there are from the start of human, and its impact has like cascade effects. And the first one is sea. It is the utmost important for us because it absorbs the 26%, close to 30% of the carbon dioxide from humans, and absorbs more than 90% of heat from atmosphere that we are living in, and likewise to the increase of the average heat from the Earth's surface, the sea also, the temperature of sea has increased more than 1 Celsius. 1 Celsius doesn't seem very much, but it took more than 200 years to increase just 1 Celsius. Now, just last 2 years, it has increased more than 0.3 Celsius. 0.3 versus 1 in 200 years. So 1 Celsius is very important, but problem is it's from now on to 230, the deadline, and 250, and 200 at end of this century. And when we look at the facts, if we have more than 1.5 Celsius, it was expected 10 years ago it will be around 2030, 6 years from now. Now, I believe from looking at the statistics, we will reach 1.5 increase in 3 years. Because we already have 1.34 from 2 years ago. And if we have a 1.5 increase, 70% of destruction of coral reef, that is very important. Coral reefs are very important for the reservoir for a fish, and it protects the tsunami and storm, the wave from the sea. So it does protect us. It provides the food for the fish. So if the coral, the reefs are destructed, there will be 20% less food that we eat. So as I've mentioned, over the more than 200 years, we have now over 20 years 4.5 times higher, very steep increase, and food price and inflation rates will be affected by this the climate change. Sea level, many don't believe it. I don't still believe it, because only like 0.5 millimeter each year. But when you look at in Japan, it has increased 0.4 millimeters every year. In 10 years, it will be 5 centimeters. And at the end of this century, there will be more than 50 centimeters. If even we limit the temperature rise below 2 Celsius degrees. But most likely, if we do not try harder, it will go up to 3.8 at the end of century. Then most likely there will be 100 meters the rise of sea, and maybe 10 to 20% of Japan will sink because of sea rise. And it has great impact, not only to Japan, but Korea, many areas in. So, problem is, we only have, they say, I still don't believe, I don't have this close feeling, but only 11% chance to keep 1.5. I think it's unrealistic anymore. We have 34% chance to keep it under 2 Celsius. It is also unrealistic. Looking at the figure for the last 3 years, I think it will go up to at least 2.8, as they say in the report. And this graph shows close correlation between temperature increase and carbon dioxide, very close relationship. But when you look at for the last 20 years, there's a steep increase of temperature as well as increase double, almost a double. Now, this was 2022, 2024 is more than 450 ppm of carbon dioxide. That is about double of 20 years ago. So this is a fact. So the carbon emission by country, China accounts more than 1/3. South Korea, unfortunately, ranked 10. Taiwan, fortunately, 24th. But these 10 countries, they produce the carbon dioxide up to 76%. And China, by just itself, account close to remaining 9 countries. So it is becoming very serious problems. And when you look at for 20 years, 30 years until 2020, there was only 20 gigaton of the carbon dioxide, but for last 4 years, 25 gigatons. So currently, last year I reported 85 gigaton. This year, more than 95 gigaton. It will be expected in the report, and about 50% is from the carbon dioxide. So the carbon is the utmost important the portion of the greenhouse gases. But if you look at another report, the fossil fuels still contributes 80% of the global total energy supply. 2 years ago, now it's 85%, still 1.5 increase every year. And it has increased more than 1%. And problem with is there's only 9.5% the clean energy, renewable energy in 2022. Now it's 12.5%, but still it's much less than we have promised to have this renewable energy. And the food system contributes up to 30%. The agricultural emission, but increases 22% of last 20 years. And when you look at this meat, the graph, it shows that the Africans has least excess consumption of red and the processed meat, and Africa has the worst the outcome from climate change. Although they don't eat much of it, they don't contribute much to the CO2 emission, but they are the one of the countries that have the greatest impact, negative impact from climate change. We know that many the effects from climate change, melting of glacier, rising sea levels, I've mentioned, natural disasters, impact on vegetation, impact on the food chain, and warming of oceans, acidifications, affecting the coral reefs, and less food. At least 10% of fish within every 5 years will be lost. And climate change with the wildfire, and you look at the graph, there's increasing everywhere, especially the North Americans and many other with the warm areas. Most important, the food security issues, more than 5 to 25% loss productions from the rice and other the crops, and increase of food rice. For physicians, I think the utmost important, the effect is health risk. Not to mention that some mostly overlooked is mental and psychosocial health. We sometimes and many times overlook this issue in the area. Just another striking news is if the temperature goes up 2, I think it will happen within 5 or 7 years at least. More than 50,000 new viruses will be spread around it was reported, I think, Nature 2 years ago. So it is pretty confident, the report. And you know that the Arctic area has a permafrost, the continuous of icing, but this has been melting. And yesterday, it was reported that almost about 90% of the glaciers and the iceberg will be melted within 10 to 15 years. And problem with the melting of the permafrost is not just the rising of sea level, because it has been the very ideal reservoir for the viruses and many other the infectious organisms, like this one, zombie virus, has been staying there for more than 50,000 years, and giant the bacteria or viruses are there. If they melt, they will be disseminate along the water down the other nations, other countries. And when you look at the statistics, 75% of newly developing infectious diseases are from animals, and 60% of infectious diseases in humans spread from the animals that we have in close by. So, but most importantly, I think the symptomatology and signs have become complex. So it has been very difficult to diagnose of these problems in the clinical settings, and there have been great alteration of geographic distribution, because in migration, not only the animals to go to better places to live, but for human beings also migration is another big issue. So we have been underestimating the mental and the physical psychosocial problems, and there will be, and we expect that unexpected death or health problems, more risk in the future. So this is 2000. I think that was when I was 40 years ago, 42. This is last year. This was predicted, actually, not recently, I think it was already predicted 10 years ago. So this will look the earth that we will be living if we were to live more than 70 years from now. Not for most of us, but back there it will be the problem. So last year, UN has announced that now we have started the era of global boiling, other than the global warming. Many don't believe yet. I don't believe yet. I hope not to believe, but it is coming, I think, from looking at the reports. So as I mentioned, the climate change is becoming the climate crisis, and it will cause the health crisis, and we're not prepared. We hope not to come. So I don't like to look at how it will change in 5 years from now, but some of you younger generation might want to check these statistics. And of those, all the impacts on of the climate change on human health, I will just talk briefly this time, this year, about health equity, inequities, and inequalities. So this is one of the cartoon or there is equality, there is equity, liberation, but reality is like this. So we need justice, not just equity, not just equality. We need justice. This is one way of having the justice, but there are other better ways like this one. So we need something like this. Equity, the equality may not be sufficient. We have to correct to make it better. So we need some justice. And all the organizations and governments have been trying up to this point. But I think it's up to the health, the professionals, physicians, are to make this with the justice. So they say, with the respect to the global inequality, there has been up to now 25% wider gap between rich and country if they were without the climate change. And the gaps is increasing dramatically. And as I have mentioned again, the consequences, the harmful effects of climate change affect most severely those populations in the world that least responsible for it. That's the inequity, inequality, and injustice. So in the past, mostly was concerned about low-income population, but there are other many factors in vulnerable the peoples, like obese, elderly, children, so on. So the low income, the areas are not just restricted to the effect with the climate change. So, and they are not evenly distributed. That's the fact. And as you look at these, some of the old pictures, this is one of, but this is the amount of carbon the distributed most densely, most seriously emitted by North America, but the least in Africa. But when you see the mortality rate with the associated with climate change, the African is the worst, although Africa accounts only 3.9% of the carbon dioxide emission. So they say, I started to believe that people facing inequalities hurt first and worst and most. So mentioned about low income, but these are other factors and people with vulnerability to have more and worse effects from climate changes. So they already have started the climate change for the action for the equity, equality, and justice. But I think we are already behind the schedule because, as I have mentioned, even we try from the government side, all the organizations, WHO, UN, even WMA, all the organizations that are working and fighting against it, we will still, they say, reach at least 2.8 at the end of this century. This is, even we try best, will be the fact. So it will have faced more than 3. So it's a double, it will be double of what will be in 2030, 6 years from now. So this is what they say from by the experts. So we are already under unsafe levels of the climate change. So it is becoming a climate crisis. This is showing now for us, for the first 5 rows. Most likely we will just face 1.5 increase next 10 or maybe most likely 20 years. But those from back rows will have, at least from here, and those who are born from now will face 4. So this is very high, very serious, up to 4 Celsius increase. And these are some of the figures. Sorry, it's written in Korean, but the statistics will go the exponentially, as you see. And how much time do we have? They say, I think to make an inflection point, I think it's 6 years from now. If we do not cut down 40%, there will be 1.5 increase. But this is estimated 5 years ago. Now, I think it's only 3 years. If we don't cut 26% for now, we'll have 2-point increase, 2 Celsius increase. If we do not try enough, there will be more than 3 or 4. So they say we only have 4 to 6 years from now to come to inflection point. So we know what we have to do, like one we have yesterday, Green Initiative, ESG. We know all about what we need to do, but we just not trying our best. And like Trump administration will most likely leave the COP, the 2030 from next year, I think. The richest countries are leaving because they still depend on much on the fossil fuels for their energy. And we know the answers: cash, capacity, control. But for our side, for the physicians, healthcare professionals, I think the education is utmost important. We have to be prepared for unexpected the effects from the climate change and climate crisis. And I have started a couple years ago, 4 or 5 years ago, to set up the first time in Korea, the climate medicine. And I was finally ready last year, and I was supposed to start to teach this March. But our students left. Our residents have left, have not come back. So I couldn't start. So I only collect more data. I collect and prepare the protocols and educational materials. Thanks to them, I have enough time to prepare for the future. But all these organizations have fought, still fighting, so many, including World Medical Association, WHO, UN, and you know the UN SDG goal, and specifically 13 it was allocated for the climate action. But we are still much behind, not just for the funding, but with the other actions. This was made. The promise was made 2015. The famous the Paris Climate Agreement, keeping the temperature 1.5 by 2030, which is now unrealistic. They were hoping to keep it under 2 within the end of the 2050. That's about 25 years now. This has already become unrealistic. I found out that it is unfortunate that Taiwan couldn't join the UNFCCC, but last year I reported that the COP28, which was on Dubai, all they agreed was that the funding was only 30% of what they needed. So there was a failure, complete failure. And they know that the global carbon emission continue to rise 1.5 every year, where we need to reduce by 7% annually. So there's a great gap from what we're trying. And the funding, the final funding was only less than 1% of required. So it was determined the complete failure. And this year, last month, COP29 in Baku, although they agreed to put $1.3 trillion, but only $300 billion were allocated for the developing country, which was far less than they needed to accommodate these risk from the climate change. And they also did not make any commitment to reduce fossil fuels. And it is most unlikely this year and next year, the many rich countries will not join of this promise. But so they say last year in Brazil, the COP30 will be the last chance to avoid irreversible rupture in the climate system. So, but even we achieve some in acceptable range. As I mentioned, it is already a bit late than we wish to hope. This is Taiwan. As you can see, this was just a steady increase until like 2 decades ago. Now, last 3 decades was steeper. Now, last 10 years it's even steeper. So, report indicates that the Taiwan also will face at least 1.5, 1.8, and up to 3.6 at the end of this century. And when you look at this graph, since 1995, there's never a decrease of temperature, only the increase. But thanks to, I congratulate Taiwan of their trying a net zero emission project, started 2022. Now, 2023, last year, you have decreased 1% less than previous year, where other nations in average increase in 1.5. So there's 2.5, yes, better the outcome. And still, as I mentioned, the Taiwan was excluded in UNFCCC, but they continuously, as we have seen this last month, they're continuously trying to make the promise as UN SDG goal and in Paris, the commitment. Health sector, they account about 5% of total greenhouse gas emissions. So we have our responsibility, at least 5%, healthcare sectors. So, but we do not think very seriously. I asked yesterday when this was started, Health Hospital Initiative, they said, you said started this year. But I think it has to accelerate faster than you have planned. We know what and how should be done, and these are some ways, and it includes the political actions and supporting the communities, and in everywhere, like one you have started here. But I think for the physicians and healthcare, people, I think we not only need to prevent of these the health issues that are caused by climate change, but if we want to have enough, even not all, but if we want to tackle, if we want to at least mitigate, even not to cure everything, but we need to develop better system. And it needs the education system. I think it's not only education system, but it's the continuous, lifelong continuous CME, CPD, the programs that needs to be started, I believe. But the U.S. has now 55%, close to 60. It was 2019. I found out this morning was at 62% U.S. schools have started teaching climate medicine to medical students. But still, other areas in the world, less than 20, about 15% only are teaching, not the climate medicine, but just climate change issues, not the regular independent course, not the CPD, CME courses. So this, I think, is a major problem. So I made a call for action for implementation and integration of climate medicine in our medical, the education, in continuously, every year, from first year, second year, third year, last year, and interns and residents and the specialists or continuous medical education. So to end up, to sum up my talk, it is a fact as of 2024, there has been 1.34 increase rise. It took more than 200 years to increase 1.17, but last 2 years have increased more than 0.17. So it is now 1.34, very close to 1.5 already. So it was average in 17 Celsius, now it's 18.34. You don't think it's 18 degrees is hot, but it is average in global. So it is very serious problem. It is increasing faster than expected, especially last 2 decades, even Taiwan and many areas. And no regions are untouched and unsafe. And problem with equities and equalities, the countries least contributed to global mission, they are most worstly affected. And climate change affecting global health in equities, in equalities, and that's the problem. And we have overlooked intentionally or helplessly being avoided to the economic the stagnations these years. But this will not be any more excuse for the future. So it is time for urgent need for the action to prevent disaster and health issues from climate change. But I believe that still not enough regional global actions and collaboration. I therefore urgent call for professional medical education to be implemented for the future. But I think if we start putting our efforts harder and harder, more and more, I think we can make, for my estimation, although I'm not an expert, but from statistics and scientific fact, I think we can make it stop at 2°C rise at the end of 2050 if we try hard enough. So I still think there's a hope for the future. Thank you very much.
Thank you, Phillips and Park and Kloiber. And now we move to because the time is limited, so we move to the next second section, okay? If needed any break or to toilet, you can just for yourself, okay? It is our honor to have the Professor Dr. Wang Zhenxu, Lecturer, Taiwan, and the Professor of Medicine, College of the Medicine, Chongqing University, to serve as our moderator. Please join me to give a huge applause to the Dr. Wang.
Okay, thank you for Dr. Lin. I'm Dr. Wang from the legislation. It's my honor to moderate the following section. First of all, I will express my deep appreciation to the previous section from Dr. Kloiber for your good moderate, and from our two distinguished speakers, Dr. Philip and Dr. Park, for your very, very excellent and very informative speech. I'm very happy to enjoy your talk. To this section, we will have two local speakers from Taiwan. The first one will be Dr. Brian Zhang. Dr. Brian Chen is an established family medicine specialist and has been working in primary care and community medicine for decades. He is the incumbent Secretary General of Taiwan Medical Association, Vice Chair of Public Relationship and Wonka Committees, as well as Board of Doctors of Taiwan Association of Family Medicine. Dr. Zhang has devoted himself to the World Organization of Family Medicine community for more than 10 years. He served as the president of WONCA in Asia Pacific region since October 2023. He did several research programs such as NHI Family Physician Integrated Care Plan, the Community Health Care Groups since 2003, the MOH study of building community health care network, and the CDC SDC Clinical Introduction and Education Plan since 2010. He is a renowned expert in primary health care, community health care network, hospital administration management, and the cooperation between different hierarchical levels of healthcare system. Today, he will give us a talk entitled as the Taiwan's community healthcare groups serve as the foundation for an integrated healthcare system to provide universal health coverage. Let's welcome Brian. Dr. Sang, please.
Thank you, Professor Wang, for your great introduction. Our president, Ashok Philip from the WMA, the council chair, Dr. Park, and the Secretary General, Dr. Otmar Kloiber, and all the honorable guests, speakers. Thank you very much for joining today's seminar. And before my presentation, I want to give my deepest gratitude for the three very important persons from WMA for you coming to Taiwan. Is this because of your coming that we have the opportunity to show the work we've done for the global health, and we have the opportunity to work with the WMA that with your support that we might show our strengths that we can share with international medical communities. And today is also the healthcare exposition here in Nangang, so maybe after this conference, you'll find some time to visit. I see so many healthcare big hospitals, medical centers and regional hospitals. They have their exhibition showing the AI and smart medicines. So I think you can also see what the progress here in Taiwan. Today I want to share about the model that the Philip just said, that the primary health care is the Taiwan is showing great strength in the universal health coverage is because we have a strengthened primary health care network, and this network is called the community healthcare groups. We have worked in this for more than 20 years, and this presentation I already showed you in Geneva this year, but I just brought back here to Taiwan to share with. So there are some medical students here, and we also have a live broadcasting, so we can share the achievement here to the people who joins us online. As you all know, that the primary health care should be the foundation of the health system, and with the evidence that the strengthening of primary health care could improve the health quality, reduce the cost, and increase the national health status, and also reduce the health disparities. It is not well understood that we have the tragedies in 1999, the big earthquake in the middle of Taiwan. It caused the death of more than thousands of people, and also the SARS attack in 2003. That we understood that the community network is very important, because during these, whether it's a natural disasters or the pandemics attacks, we need medical services to the location that suffers the most. And in that time, we can only send the doctors from the big hospitals to that place. But as you know, the recovery of an instance, it takes months, even takes years. So after a period of time, those physicians, they go to the middle of Taiwan. They have to go back to their workplace. So maybe one month, 2 months later, still we have to left. We have to leave the medical problems to the regional resources you may have. So that is the point. That is the time that our government are thinking about. We should set up a model that encourages the collaboration, the integration of the community medical resources and that is the starting of the Family Physician Integrated Care Plan. It's starting from 2003, just 20 years ago. And these healthcare groups, it needs 5 to 10 GPs, and they recruit patients from the communities, and they delivers continuous and comprehensive care, such as 24-hour call center, health promotion. They do the health promotion to the community. They do disease prevention and treatment. They do case management, and if in need, the patient needs to further checkup or further treatment, they refer the patient to the hospitals. And these clinics, these GPs, they have regular meetings between them and also with the hospitals. They're working with them, and they will share the experience. I will show later in later slides. And they also have the shared OPD clinics in the collaborative hospitals. So it gives a connection between the GPs and the hospitals in the communities, that they will become good friends and they have good connections to deliver the continuous care for the patient. As you can see that the GPs, I should knew this. The GPs, can you see the point? Oh yes, the GPs work with the community hospitals together, called the CHCGs, the community healthcare groups, and they work whether it's acute or chronic care, and they also work with the medical school, so medical students can go to the community to learn about the community medicines. And they can also refer the needed patient to the medical centers. And through the case management, disease care, and also the family health worker is the first step of Taiwan's digitalized health record. They're requested to do that in the CSCGs. So it's the first step in our Taiwan's digital medicine. And so the thing is that if we want to encourage the communities to join this project, we need to find the money. And how can we reimburse that? Those clinics, they join this project, they just do the regular claim for the insurance as usual. But if they join this project, they can have the extra bonus if they can save money. So we will have the algorithm to predict the medical expense of the members they taking care of during the year, and at the end of the year we will have the actual expense of those members. So the difference between that, if they save money, those money they saved will go back to this community, to these GPs as their bonus. So it will encourage the physicians to use the most effective ways to taking care of the patients. And of course, there should be some KPIs, such as 24-hour call center. You may see that it should be very suffer bothering for the physicians to get the calls from the patients to 24 hours. But actually, the patients in Taiwan are really thoughtful. You might guess that in my CHCGs, we have more than 10,000 patients we're taking care of. You might guess in 1 month, how many people will call me at the middle of the night? Over 10,000? No, much less. Only 10 to 20. It's because they know the doctor needs sleep. So unless it's very urgent, they will call you. But once you pick up the phones, they will be really loyal to you because they know this is your very good family physicians. when the time we need, we can find you. And sometimes just one call, one consultation can relieve the suffering for the patient. Maybe you just explain to him, and he will know he can wait until the next morning and go back to your clinic. You don't need to go to the ERs. So I think this is the function of these ideas. And of course, we have to fight the budget with the government for these projects. Now we have 6 regions. And there are totally, in 2022, we have totally 609 CSCGs here. And the operating budget is $0.12 billion US dollars. It's increasing. We're trying to we have to show the achievements. So I will show the performance here, so you will know. And now we have more than half of the clinics join this project, and it includes 46% of total physicians in Taiwan. And the population, 1/4 of the populations are the people already joined this project. We're talking about partnership. We said about the clinics. We talk about the hospitals. This is how they work together. Each month, we will have a case conference. We pick up a case from the clinic, such as here we can see the patient with the bilateral leg and scrotum edema and have dyspnea. So they brought this case, and they have doctors from the hospitals and doctors from the clinics. They have these seminars and talking about the case. And the young doctors, the residents, they have to read the new medical journals. They find a new concept of whether it's diagnosis or treatment of these symptoms, and sharing together. So through this sharing, we will know that the physicians in the hospitals and the physicians in the clinics, they will share the knowledge together, and they'll share the experience together. So sometimes the public in Taiwan, they might see that the physicians in the hospitals is better than the physicians in the clinics. But through this process, we will know that actually many of the physicians in the clinics were the well-experienced or well-trained, maybe professors in the hospitals, and they go to the clinic. So through this, that we will show that we are all the same, and some of the young doctors will know how their seniors can make the diagnosis only through the physical examinations without a fancy laboratory tests such as MRI or CTs. So they can learn from each other and grow together. And except for the seminars, we also have the workshops. We can choose some topics. And these are, and also we will provide food, good food. So the physicians will not only share the knowledge, but they also share the food and share the drinks, so they can become friends, really friends together. And we have health education to the community people. And even through the COVID period, we use the virtual meetings. So we continued that monthly meetings together. And these are the feedbacks from the patients. Because the patient, once they refer to the hospitals will give the caring cards for the patients and the thank you card for the physicians from the clinics. And the patient's feedback will say, oh, very thank you, Dr. Brian, thank you for referring me to the big hospitals. And when I come back, they give me good services, and they will refer them back to my clinics. So when they are admission to the hospitals, they will not be very frightened, because I will also go to the hospitals to check my patients, and I can see my patients with the visiting staffs in the hospitals. So the patient would like the continuous care on this process. And so let's see the performance. In in 2021, we have 5,300 share clinics, and the health educations are more than 24,000 people, and we got 24 hours calls, and 90% of the enrollees, they're satisfied with the CSCGs, and 90% they're satisfied with the two-way referral. It means that when you will refer to hospitals, when condition gets stable, you will be referred back to the clinic. So people stays in the community for care unless it's urgent and need a treatment in the hospitals. And more than 80% of the enrollees, they preferred consultation with their family doctors before seeking medical attention in hospitals. And this is very important because they build the trust between the people and the physicians in their communities. So they don't need to, even you all know that in Taiwan's health insurance, we can have free access to any medical facilities. But through this process, people will know that they can consult their community doctors first before they go to the ER or the hospitals. And that might find a way to make sure that the medical efficiency. And this is what we published in 2011 about this, the good things, the benefits, the advantages of these projects. It reduced clinic visits, increased satisfactions, strengthening the service of patient referrals. And we also do more preventive programs. You can see if you join the people join the project, we'll have more periodic health examinations to those who do not join this project. And they do more pap smear. And the medical expense saved, the difference was around $300 per year per patient. And the OPD visit was less than 2 visits between the enrollees and non-enrollees. So we have more ways to go because there are only 1/4 of the population join these projects. And if we can move on to more, have more, then we can save more, not efficient OPD visits. And also they have shown performance in COPD care, diabetes care, and the people in this project, the patients, have better HbA1c, LDL, and microalbumin control. These are all published in the BMJ, BMC. And what is more, we set up this platform for these community collaborations, the CSCGs. The thing we need is we'll put on the different items so they can do the service for the people. Just like this. If we take this already, we take the network there, we can have home visits for we just said the geriatric care, and we just put incentives to the CSCGs. They already have connections with the community peoples. And as for the H1N1, enterovirus screening, cancer screening, smoking cessation, weight control, vaccination, we just change or add on the KPIs so we can encourage the CSCGs to do that to their patients. And especially during the COVID period, the 6 most important things for the GPs are the home care for mild cases, diagnosis through fast screening, evaluation and prescription, and vaccination, PCR testing, and fever checkup. And this can also be requested for our CSCGs to do. So you can see with the telemedicine care, among the total nationwide 7,520 clinics, the majority of the CSCG clinics, they do the telemedicine. And for telehome care, because some of the minor cases, they don't need to admission to the hospital, so they just stay at home. And they will need a physician to call them and discuss with the patient about their progress through the virtual consultations. And 100% of the CSCGs, they provided care. And more than 78% of the nationwide is the CSCGs. So it seems that the CSCGs, they provided high participation, multiple channels for providing the patient with the COVID vaccinations, and they have good results on this. And the future plan for this is that the National Health Insurance Administration wanted the CSCGs to control about the high medical expenditure patients and proactively manage the chronic care and provided community care to the long-term care systems. So that's the further work we need to do. So in conclusion, the values of CSCGs, they have health policy participation, they have high health prevention, high health promotion, and they might be the gatekeeper in the community. So the model of community healthcare groups can provide health for all through the integrated healthcare system and the patient-centered quality care. And I provided you these models for you to think and discuss with us. Thank you.
Thank Brian, and congratulations for you to achieve a big success. Okay. I'll move to the last topics, hospital-based and community-oriented universal health care for the elderly. I'm glad to have this opportunity to introduce Professor Li Mingzi. Professor Li is currently the senior consultant of Taichung Hospital, Ministry of Health and Welfare. He is the co-chair of Scientific Committee, IAGG, Asia and Oceania region, and the chair of International and Scientific Committee of Taiwan Association of Gerontology and Geriatrics. He will give a talk as the title, as I said, hospital-based and community-oriented universal health care for the elderly. Let's welcome Professor Li. Okay.
Okay. Thank you, Mr. Chairman, dear colleagues, and my pleasure to share about the first one. My pleasure to share about the hospital-based and the community-oriented integrated care for the elderly. And the most honor to me is my three big boss here together. The big boss is Minister Chu, and the second boss is the public hospital administrator, Professor Lin, and my department head, Dr. Liao. Three boss, they are all here. I think they are more likely to monitor my presentation and to make sure no mistake will be made. Okay. Let me try. Taiwan has a population of 23 million, and the GPD is about $3,300 US per capita, and the average life expectancy is 81 on average. And 100%, nearly 100% people covered by the national health insurance, and they enjoy a nearly free medical care. And Taiwan has a 3-tier of medical care system composed of the primary care, including the public community health center and the private clinics. Secondary care is provided by the community hospital, and the tertiary care is provided by the medical center. Linking the 3 levels of care, we have a national official informatical-based mutual referral system. There are 3 milestones of the healthcare reform in Taiwan. The first one is in 1995, the performance of the National Health Insurance Program to make sure medical care for all. And from year 2013, the government decided to integration of health care and welfare service together in one ministry, one policy, one strategy, and to provide integrated care. And moreover, from year 2013, years 2017, we integrate not only medical care and the welfare service and the advanced long-term care together to meet the needs and the demand of a rapid aging society. Accordingly, the medical education reform in Taiwan has started since the early year 2000s. And the AV medical graduates, they need complete 2-year PGY, including the training for general internal medicine, community medicine, geriatric medicine, before they opt for any kind of special residency training. This is a national frank wall of care to make sure people, especially the elderly people, receive a patient-centered, timely, effective, efficient, equity, quality care. We need to rely on, first, is evidence-based medicine and science, and the second is continued quality improvement. And the third is patient and their family engagement in care, like the ACP and the SDM. And the first, we need a strong information system, and the last, a multidisciplinary team approach is necessary. And the integrated care is the key to achieve a comprehensive and a nice patient journey from the health promotion to the acute care, subacute care, to the long-term care, to home care, and to end of life. And you want cover both before visit, during visit, and after visit, a good care. The integration is the key and to work for. I'd like to thanking Brian. He mentioned, he talked a lot about the primary care. Let me focus on the hospital. And I want to raise an example of a public hospital belong to the Ministry of Health and Welfare. That's Taichung Hospital. But I want to say most of the hospitals do the same work. I just raise my hospital as an example. And the Taichung Hospital has a history of 129. We have 630 beds and another 190 nursing home beds and 30 daycare beds. And we also cover nearly 300 home care cases. And the mission of the hospital is to provide the Taichung citizen with a patient-centered and community-oriented quality care. To achieve the mission, we relied on our organizational culture that's quality is life and driven by the education and the research, and we highlight the teamwork, and also our staff is the treasure, and the business is a good business is a foundation to run a hospital. Let me introduce our integrated care for the elderly in the hospital and in the community. We provide a lot of a variety of community preventive service in the community, mostly in the community. And then we provide acute care, post-acute care, home care, and the hospital at home, and the daycare, and the long-term care, and even the end of life, palliative care, and the hospice care at the hospital or at their home. First, I would like to introduce the integrated outpatient service. And multidisciplinary doctors, coupled with the case manager, nutritionist, and the receptionist together to provide the elderly integrated care and like the ICOP assessment, consultation, and any kind of geriatric syndrome problems in one clinic. You can see doctor, the case manager, receptionist, our pharmacists review their medication in one clinic, and we call the Evergreen Clinic. And in the geriatric ward, every patient will receive the CGA and the functional recovery program. So we don't want only focus on their medical problem. We focus on the syndrome and the functional recovery. And Taichung Hospital is the first hospital in Taiwan to initiate PAC. I was sent to the University of Michigan and the University of Minnesota for the model of the post-acute care. Then I brought back the PAC care to Taichung Hospital. Then it's 10 to 26. The public hospital belongs to the Ministry of Health and Welfare. Now the whole country, they run the PAC and very welcome by the people, by the family. And you know, nearly 90% of people receive PAC, they can go back independently, nearly 90%. And in the United States, they only 60%. We learn from the United States, but in Taiwan, 90% can somewhat independently go back to home. And the other 10%, the remaining 10%, we will arrange the community care for them, like the home care or nursing home care for them. However, the achievement is great. So in the post-acute care ward, we equipped with physician, PT, OT, social worker, nutritionist, pharmacist, psychologist, and I have to say, the case manager is very important. they know everyone. They can arrange all the aftercare for the case. And then you will find the outcome is great. The ADL, the average ADL is about 40 when admitted to PAC, but after they go home is about 71. And the other achievement in our hospital is we initiate a Taiwan PACE. The Taiwan PACE means all-inclusive care for the elderly in a daycare center. And we also learn mostly from the University of Minnesota. And I found some scholars also from University of Minnesota. And they believe people don't want to stay at hospital or institution, but when they stay at home alone, their family just cannot be easy. Let them only stay alone at home. So the better way, send them to the daycare center. However, most of daycare center, they don't allow the resident, they have a major health problem with their residents. So our all-inclusive daycare center is running by the hospital, and we allow any kind of any level of the condition can be go into the daycare center. We have 30 beds, and in the daycare center, we have provide meals, leisure activity, rehabilitation, health consultation, and the muscle training, and many things together in the daycare center. And the ICOP assessment and the 4M model will apply to all the residents in the daycare center. And we also have a 190-bed multi-level nursing home in Taichung Hospital. And we have a great reputation because we have a long list waiting for register into the home care nursing home. I believe it's 300 waiting list because we take so good care of our residents, and they are long life. They are long life. We even have about 100 years old, and they stay more than 30 years at our nursing home. Yeah, and the 3 doctors who take care then already died, but the residents still alive very well at the nursing home. So we are proud of the quality of our care. Okay. And the hospice care has been provided at home and at the hospital, and we have 12 beds of hospice at our hospital. And for home care, that's the last I want to share with you. And we have, on average, 250 cases under the hospital care. We deliver home care to about 250 to 300 patients at home. And we also provide the hospital at home care. And in the middle Taiwan, the first case of the hospital at home is in our hospital. So because we belong to the Ministry of Health, and so we must have some achievement or record as the example. So we do the hospital at home. And we welcome international collaboration and many research and innovation in coupled with our international colleagues together. And the last, but never the least, is the ICT, because Taiwan is good at the ICT. So it's very, very good for the SDG through the ICT. And the digital transformation is ongoing and will be complete by the year 2030 through the electronic medical record and the electronic health record and the national universal cloud. And we will achieve the digital transformation and the AI era coming. And in conclusion, I would like to say both the primary care setting and the hospital is the same home, is the one home. We should work together to make sure people receive a continuous and integrated care. Thank you so much.
Thank you, Professor Lee. And thank you, Professor Wang, and Professor Zhang, and Professor Lee. And we move to the Q&A session. And we now invited Dr. Tsai to be a moderator, okay? And all speaker and and if you any question, you can raise your hand, and our staff will give you my phone to you. Yeah. Okay, any question? Okay.
Excuse me, I'm Dr. Jung Yul, served in Taipei City Hospital, and I have an echoing and a question for Dr. Park, because your topic is climate change. And actually, I serve in the Taipei City Hospital, and it is a public hospital, and covering the distribution is a community which is very old. The elderly population is the majority, and the building there is so updated. So you can imagine the people there is so fragility. And under Taipei City's evaluation, is the most hottest area in our capital city. So I know what the impact for the elderly. I know. So I have a question that as I am a doctor of the primary care level, this is the majority of the doctor's question. We know the environmental impact or environmental policy. Maybe we can do a lot as we are the manager of the hospital or the community manager. But as we are the primary care level physician, okay, served in the hospital or the community, what we can do for the patient about the climate change or the climate or the global warming impact. So if I want to ask, do you have any suggestion for me to do for the patient? Thank you.
Very tough question. Well, as one of my slide, there has been estimation of 25% increase of the harmful effect from the climate change to the health status of those are mostly chronically ill patients like COPD, the heart problems and lung problems, asthma, allergy. So whenever, I think that there should be another program attached to the regular, the primary care system to screen, monitor, surveillance system to check if there are any uncertain, any any suspicious, uncertain status of patient from unknown cause, if they have been exposed to the heat area or cold area, as I have mentioned, these people died from like 146 last year from Taiwan, from northern part, the Kaohsiung area. So whenever, but they didn't die because of -20, -30. They died mostly 5 or 6, hypothermia. So what I'd like to suggest is that if there are some changes when you have the close monitoring of these patient regular checkup, but if you see something different or some other changes, there should be a program or protocol to ask them to make sure whether they have been exposed to other areas like trips or traveling or visiting other the family members, to make sure they have been exposed to not only the weather but other areas where there are the common with the infectious disease or other the problems related to the health situation. So it will be very important to monitor where these have come from, even in like Taiwan and many other areas. So I suggest that you need to have additional sort of a monitoring system for the chronic patients, especially, as well as acute patients if they are showing something different, symptomatology or signs that are not according to what we have seen before in the textbook. So it may not be the climate change cause, but it may be something else, but we'll still have to have a suspicion to make sure for the future reference.
May I give an example of what you practically can do as physicians? This is to work with your municipality. I'm living in France, in a very small town, and every spring I get a letter from my community with an emergency number and a program to sign up for heat emergencies, which is being sent to all people over 60. And the community looks for rooms which are climatized. They have volunteers and staff people who take care of elderly people who wish to have services and help in case of heat emergencies. And then they can be taken away from home if they so wish, brought to rooms which are climatized in order to be safe and to be looked after. And this is something which now more and more cities and communities do. And what you can do as physicians is to go to your communities and ask them to prepare for this, so that there is made sure that the communities take care of the elderly people and help them not to be subject and victim to a heat wave. Very practical, pretty simple, doesn't cost very much, but is pretty effective. However, let's not forget we have still far more people suffering and dying from hypothermia than from hyperthermia. So, and this of course affects mainly elderly people, but also homeless people during the winter time.
I'd just like to add the careful monitoring for children as well, because they often be left in the car, exposed to heat that it's been drastic, the increase inside even cause death in 2 or 3 hours if they are left in the car.
That's manslaughter.
Yes, of course. And you have to be careful about these patients, the children, as well as those with endocrine or metabolic syndromes, the immune disease. So we have to look for those the areas with these patients. If they show any other signs, any other symptoms unclear, you have to report. You have to monitor close surveillance. Thank you. I cannot agree more with your suggestion. Now the groups now suggesting and asking governments to have mandates on not only the calorie, the information on the product, but they also like to have these carbon footprints on each item, especially the food and drugs. And I think that will be very helpful for the consumers to choose which product that we should choose.
May I disagree?
Sure. Disagree?
Yeah.
Sure.
I respectfully disagree with that. I think this is the mitigation, but also the prevention in health is a matter for the professionals. I think it's very dangerous to charge our patients with the awareness for environmental consumption in healthcare. The treatment has been done according to medical standards and medical guidelines and what is necessary. It's up to us to look that we do this with the most care for the environment. But I think it would be absolutely wrong to charge our patients to be responsible in healthcare for looking for the environmental awareness there. You can do this with your pasta or your burger, but whether you need a diuretics or a beta blocker or an antagonist for treating your high pressure should not be decided by any environmental suggestion. And I think, therefore, it is wrong to charge the patients with a suggestion. This is up to us to take care of that and to make sure that we are acting environmentally cautious and safe in our hospitals, in our clinics, in our practice, and in the choice of the tools we need. But it must be in the best interest of the patient, and patients should not be burdened with that at that point. Thank you.
I fully agree with Otmar, but I disagree in some aspect, because there are so many copy drugs, so many the brands, and so many different. And physician side, we don't have enough the information. We do not have enough personnel to go through this. I think it is up to. The government should assist for us. And I think up to some point, I think it should be transparent to the consumers, including patients, the information that it is with their products.
I'm expecting Dr. Professor Cai Dujian. If you have any question,
to someone else.
Yeah.
And my concern is that since I'm working on an international company with home base in Taiwan, before that, we are the major international partner supported by our government to facilitate our cooperation with the Southeast Asia country. And also, we, in year of 2011, we have a Kodabaru Declaration that is formulated by major university in Southeast Asia and the Monash University in Australia. What we attempt to do is to harmonize the bioethical engagement in Southeast Asia, and also extended to the Middle East because in Kota Bharu. And also, my friend is Yo-Min Lee and Taiwan Huang in South Korea. So I think that these two leading doctors already help us evident that, well, we think that while we work with Southeast Asia country, we find that those people are really, really smart in the sense that they can solve their question with a very sophisticated and cost-effective way. So I think that I would like to take this opportunity that since the leading figure of World Medical Association is here, and could we, under the leadership of our Taiwan Medical Association, Dr. Chu, and let us establish a collaborating center here, because I think that this will be worthwhile for the World Medical Association in the sense that Taiwan is really good to translate the all Western wisdom, especially in medical arena, to implement here and establish a very comprehensive, community-based, community-oriented healthcare delivery system. Also, we have the really good universal health insurance. And secondly, I'm thinking that once we have the collaborating center here, I think that we could collaborate the wisdom reversely, that we can work with South Korea to learn a lot from the Southeast Asian country, our partner, to learn how they deal with their issue in most cost-effective way. So I think that those kind of mutual learning should be a very good opportunity for global achievement and further global engagement. Especially in Taiwan, we already have the AI linked with the medical arena and also support the ESG for bigger industry. We already implemented in rural counties in Taiwan for administrative purpose. We think that this kind of wisdom probably could learn more and get feedback from all of you. So this is my comment.
Thank you. Thank you very much. I will ask our Secretary General and President, because they are representing the WMA. But we also currently have 6 centers, like one in Korea, South Korea, is Yonsei University. They have an environmental medicine medical center for the collaboration. So I will ask Otmar and Ashok.
Yeah. Takes the time. Thank you very much. Yes, we are always interested in having such collaborations and cooperations. What we do usually is we look for, is there a project that we can do together where we can look for answering a question? For instance, integrating AI into medical care. Very pressing problem right now for many countries where we need solutions, where we need to learn, where we need to see what are best practices and so on. And I can only invite you to contact through the Taiwan Medical Association and contact us, and then we try to find out where we can cooperate and start a project with that, and that will lead to a cooperative center then.
Yes, I don't think I can add much to what Otmar said, but the WMA's strength is, of course, its collaboration across the world with so many medical associations. So we can always act as a conduit between the centers that are already established and those people who need help, who need advice, who need guidance. And of course, we can't be putting in a lot of money, but we can certainly be putting in a lot of effort and helping where we can. We know that Taiwan is a leader in this, and yesterday we saw that the government has a very strong commitment to meeting these ESGs. Previously, I think a lot of medical products, as you said, were excluded from these, from CFC guidelines, etc. But we have, I think, as a profession to start moving towards environmentally sustainable medicine. But we have to do it as leaders, as the profession must lead. We can't say, please lead us to the politicians. We can't say to the patients, show us the way. We have to show the way. Thank you.
Okay. Before ending this Q&A session, I would like to thank all the panelists for your active participation and all the audience from the floor. And I would like to raise one key word and one slogan. The key word is globalization. That's a business word, but we public health sector also use this. So we should think globally and act locally. Okay. And for our colleagues in Taiwan, the slogan is moving forward, moving faster, and moving into the future by implementing more and more meaningful and effective measures. Thank you very much.
Thank you, thank you. Thank you all the guests. And distinguished guests, senior officials, ladies and gentlemen. The symposium is near the ending. I would like to invite Dr. Zhou Qingming to conclusion for us.
Hi. Thank you, Dr. Lin, Hen Li. On behalf of the President of the Taiwan Medical Association, I would like to express my deepest gratitude once again to our speakers, moderators, and panelists for your wonderful presentations, and to all the guests for your participation. Thank you for contribution to the success of today's events. The advance of universal health coverage relied heavily on integrated health care system. I hope this symposium will highlight the importance of integrated health care system in countries worldwide. I trust that today's brainstorming sections will be valuable to everyone. Thank you. Thank you.
Thank you, thank you for everybody. 今天的会议就到此结束，谢谢大家。如果有需要那个签退学分的，请大家签退一下，谢谢，谢谢大家。Thank you for everybody joining the meeting.
饭，吃完饭会带我来参观。对啊，有任务对。